So, in about 10 to 15% of patients on average, there is also central nervous system or CNS involvement and vascular involvement, which leads to aneurysms and blood clots. And those two kind of clusters, I guess, of symptoms are the most problematic and the most difficult to treat and the most likely to be fatal. So actually, central nervous system involvement in the Silk Road route variation of Behcet's tends to occur in less than 10% of patients. And in the West, it tends to occur in at least 20%. I've read about places where it's closer to 30%. So that's one big difference. Several other differences, notably that the Silk Road type of Behcet's affects men more commonly than women, has often intractable eye disease. Again, the CNS involvement, central nervous system involvement, is less than 10%, and it is associated with the gene serotype HLA-B51, which is what I have. On the other hand, the North American and Western Europe variation of Behcet's tends to occur more often in women than men, with treatable eye disease, more frequent occurrence of central nervous system involvement, and also gastrointestinal involvement and inflammatory bowel disease, and associated with, I'm going to read it, HLA-DRB1 asterisk 04. Now, I want to say, because there have been so many doctors that have asked me if I have HLA-B27. HLA-B27 is associated with ankylosing spondylitis. It is not associated with Behcet's disease. So, if your doctor wants you to have genetic testing done, HLA-B27 really has nothing to do with Behcet's. You should be looking at ankylosing spondylitis, and if you've got more Behcet's symptoms, I mean, you can't rule it out entirely, but in general, it's not associated. The two that I named, the HLA-B51, which I know because I've got, and in America and Western Europe, the HLA-DRB1 asterisk 04 are associated with Behcet's. So as far as genetics go, there's actually an interesting study that the Turkish Behcet's HLA type, which is HLA-B51, was actually first described in Japan as having a positive association with Behcet's disease and later confirmed in Turkey. In Turkey, the HLA-B51 type is on average about 20% of the population, but among those with Behcet's disease is closer to 60% plus. So it's not a necessary part of the disease, but it has something to do with it. The genetic factor has something to do with it. And they're not really sure at this point what triggers whatever underlying genetic or, whatever else might be causing the disease, if it's environmental, if it's viral, if it's bacterial. I believe, again, it is strep. I'm going to call it strep. So why are they calling it Behcet's syndrome and not Behcet's disease? I know when I was diagnosed, it was just Behcet's disease. The reason is because they've done these cluster analysis which show that certain symptoms go with other certain symptoms in Behcet's. So, for example, skin involvement, which I've also had, I forgot to mention, I've always had skin problems, both the acne-like stuff that goes like everywhere and crazy, that's well controlled on steroids, obviously. The folliculitis, I still get that. The erythema nodosum, which I also get, which is also better with the steroids, but that is also twofold, which I'll get to. But the skin involvement and arthritis tend together, that's one. The oral and genital ulcers tend to go together, that's two. It's all vascular problems. Blood clots in your leg, pulmonary aneurysm, which is the most common cause of mortality in Behcet's. They go together. So those are some of the clusters. I know there are more, which I've got more information at my real home, because I went to the Behcet's conference the last time. I believe they had it in the US a few years ago in Florida, but it's just jam-packed with information. I'll have to pull that out and do another video because that would be fantastic. Probably several videos. There's so much information. So in short, Behcet's is an auto-inflammatory condition, they're now calling it. A condition that affects all the blood vessels throughout your body. So basically, wherever there are blood vessels, which there are blood vessels everywhere in your body, you can have Behcet's problems there. So, I mean, not just the symptoms I've named, you can have pain in your bones, you can have nerve problems. I've known people who it's affected their organs, their spleen, their pancreas. It can go anywhere. Anywhere there's blood flow, Behcet's can affect. But it affects many organs, primarily the eye, skin, mucosal surfaces, so mouth, genital area, the joints. It can also affect the brain and large vessels of the body. It's in general a benign condition, but among especially the young, age 20 to 25, as I mentioned, and the male, it can cause serious harm. Blindness is actually one of the more common and serious manifestations of Behcet's, and when the eye disease is active, the chance for blindness is up to about 25%, depending on the severity of your eye disease. As far as age goes, Behcet's is seen but rare under the age of 16. Now, for all of you out there under 16, do not fear, because I had Behcet's symptoms, the oral and genital ulcers, nerve involvement, skin lesions, pathogy problems. I didn't mention that. I've had pathogy problems. The first time I had a pathogy test, which is they take a needle and they stick it in your skin. And it's basically an overreaction of your body to a break in the skin. And it causes a pustulate. But the first time I had a pathogy, I was on high doses of prednisone. So, of course, it came back negative. Then for a while, in my late teens, early 20s, I came off the prednisone. They did another pathogy test and it was positive. And I know for a long time I got acupuncture, and 2 or 3 times I had to actually stop it, and I've got photos, because everywhere they even put a tiny little acupuncture needle, I'd have a pathogy reaction, which was incredible. But anyway, I had those symptoms before I was 16, so. again, as people get older, the incidence of Behcet's tends to go down. Okay, so the skin lesions can present several ways. The first is like an acne-like lesion, which looks pretty much like acne, except it not only occurs on the face and like chest and top of your back, but it can be down the whole front and back and down your whole arms and legs. And I've been there, it's not fun. The second is erythema nodosum. It's basically nodular lesions, which are again subdivided into two classes. The first is a mistaken skin lesion, which is a superficial thrombophlebitis, and second, a true erythema nodosum. Also, there are other forms of skin lesions, which I have had, folliculitis notably. Also sweets. As I mentioned, about 50% of patients with Behcet's get non-deforming arthritis. Uh, 50% with differing frequency get eye disease, which is the first important manifestation. Insofar as harm goes, it is usually panuveitis, meaning it affects all layers of the eye, and often both eyes. If left untreated, it will lead to blindness. So all Behcet's patients, even if it has not yet affected your eyes, should get at least yearly eye exams to make sure it is not starting in the eyes. One peculiar aspect of eye disease in Behcet is inflammation in the front of the eye, which you can actually see like a ring of pus with the naked eye if somebody else is looking at your eyes. With the flares up and down, the body's natural response is scar formation. So if it's not treated right away, that's why it leads to blindness, because your eyes as organs will start to form scar tissue and blindness ensues. Also, inflammation of big vessels, mainly on the venous side. Patients also present with problems on the arterial side, such as pulmonary arterial aneurysm. It's a very, 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 very high risk of mortality. Although with recognition in recent years, the chance of death from this has gone down. There's also often headaches with Behcet's, and again, you all know about the fatigue. And what I have noticed is also most of the people I know with Behcet's have had just unexplained fevers, flares, especially during times of high allergies, especially spring and secondly fall. Like, those seem like the two big times for flares. And also, a lot of the CNS involvement tends to deal with the brainstem, which is interesting. I have to look into that, because when I started with the optic neuritis and meningitis, and I've had, CT scans and MRIs of my head my whole life, more or less. And when that started, bam, out of nowhere, I had a Chiari malformation. So the big difference in treating Behcet's is the line, where you have just mucosal and possibly joint involvement, and then you've got eye disease, CNS involvement, and vascular involvement, at which point you want to treat aggressively and as early as possible to give the body just a chance to go into remission. Behcet's is very different from many of the true autoimmune conditions, which present in ways that mortality risk tend to increase with time. In Behcet's in general, the mortality rate tends to decrease with time. But again, it depends person to person. And I think a lot of these statistics overall talk about just the, oral, genital, skin, possibly joint disease, and not the more serious, what I call moderate to severe Behcet's. The other I call mild, which is not, I'm not saying it's not bad, but you're not gonna die from mouth and genital ulcers, and hopefully you can get your joints under control. I know that was hard for me though. It's hard. The goal for those who require the most treatment is to immediately start with anti-inflammatory immunosuppressive drugs, including azathioprine or Imurin, as we know it here in the U.S., which is beneficial for preventing many of the manifestations of Behcet's disease. Also, I wanted to say there is a blood test called TPMT, which is thiopurine methyltransferase, which is the enzyme responsible for inactivating the toxic byproducts of azathioprine or Imurin metabolism. Patients with a deficiency of this enzyme have, of course, no enzyme activity and should not be treated with azathioprine or Imurin. The NIH advocates that all patients should be tested for TPMT activity before starting treatment with azathioprine. Well, guess what? I don't know really anybody who has been tested. I cannot metabolize it, and it actually made me so sick after a few weeks of taking it, and I was in college, and I started having internal bleeding. I passed out on the dorm room floor. Thank God my roommate heard it, screamed, called the ambulance. They had to literally drag me down the steps out to the health center, where they saw that I was bleeding internally, took me in an ambulance again to the hospital, and it was a combination of a bad reaction from Imurin and just over immunosuppression, because at the time I had not yet been diagnosed with an immune deficiency. But in addition to that, the Imurin made it very difficult for me to breathe, and I had, the tight throat and tight chest and hives off and on. And anyway, years down the road, I had the blood test, and it's this TPMT, and it shows if you can metabolize Imurin or not, and I cannot. So if your doctor is considering treating you with this drug, I highly suggest, and so does the NIH, that you go and have this test taken first to see if you can metabolize it properly or not. Because if you can't, it's basically going to poison you. And if you can, it's really a fantastic drug for treating Behcet's disease. And, it acts very promptly. So that's my bit on azathioprine. Secondly, with eye disease and severe involvement after the azathioprine/Imurin, they often use cyclosporin A, which is also rapidly acting. Plus, in addition to that, a brief course of steroids. However, a portion of patients, about 15%, I'm in that 15%, do not respond well to that treatment or are allergic to it.